Thanks very much. Well, I'm part of a team across the road. There are 5 of us working on this particular problem. Richard, Hanwar, and Claire and Lucy have recently joined us as PhD students. We're supported by Medical Research Council grants, specifically to look at mechanisms of action within these psychological treatment trials. And Richard has a training fellowship. So what am I going to talk about? Well, first of all, I'll give you some motivating examples, and then I'm going to talk about process and mechanisms evaluation, evaluating direct and indirect effects, and then I will briefly talk about modification of treatment effects by post-randomization of process variables, with specific reference to the number of sessions attended and the strength of a therapeutic alliance that's established during the therapy. So, motivating examples. Compliance with allocated treatment. Does the participant turn up for any therapy? What is the effect of treatment receipt? How many sessions does she attend? What's the effect of increasing amount of therapy? So a standard analysis of a randomised trial is what's called intention to treat, and you're actually looking at the causal effect of actually offering the treatment. Nothing to do with whether they get it. What we're interested in here is what's the effect of actually getting the treatment as planned. Treatment fidelity. Many of these therapies have a very precise model about how the treatment should work. Lots of the people I work with do cognitive behaviour therapy. They have precise models about cognitive processes and think that if the person in the therapy follows these processes properly, does the right thing, the treatment will be more effective than it would have otherwise been. Quality of the therapeutic relationship. Quite a few therapists are convinced that the actual model of therapy is completely irrelevant. All you need is a nice friendly face. If you get on with your therapist in a real way, good way, that's the thing that will work. So it's the quality of the relationship is one aspect of that. So how does that affect the treatment effect? Compliance with medication. If you have a trial of psychotherapy in, say, elderly depressed adults, for instance, one of the effects that may have, if you offer them therapy, is that they're more likely to take their antidepressant medication. That's something that's not planned in the trial, but you find that give people therapy, they stick to their medication more. So what you're asking then is, what portion of the therapeutic effect could be explained by mechanisms other than people complying more with their drugs? Substance abuse. One of the trials I've been involved in recently is a psychotherapy trial for what are called dual diagnosis patients. These are people with psychosis who are also taking drugs or excessive alcohol. And one of the theories that's quite well known out in the world and amongst the professions is that cannabis induces psychosis. So one of the ideas they had is that if you can get people to reduce their cannabis intake by this process, then that will automatically lead to improvements in psychosis. What are the participants' beliefs? So this is thinking in terms of the cognitive models that the people who develop the therapy have. They say that if you treat somebody in a certain way, you can change their beliefs about their illness, you change their behaviour, and that will then lead to changes in their illness, in their symptoms. Now there's a big mediation industry out there. Many of you will be aware of the Barron and Kenny procedure for evaluating direct and indirect effects. It was a paper published in 1986. It's had about 15,000 citations, about 2,000 a year at the present rate. I haven't looked for a few months yet, but it's absolutely astounding how often that is being cited. And it depends on the implicitly assumed absence of hidden confounding, that there are no omitted variables, that there's nothing out there that could explain the relationship between intervention and mediator and between mediator and outcome, other than the causal process being evaluated. And one suspects that the majority of the investigators using these methods are completely oblivious of those assumptions. They haven't a clue that they're the assumptions that are being used, and the results of many of their studies, if not the vast majority of them, are of unknown or questionable value. And Kenny himself, on his website, admits that this is a problem. They discuss this problem in great detail in a paper 5 years earlier, but in order to convey a simpler model which the research community would pick up easier, they simply oversimplified and forgot to tell people about this. Rather unfortunate. Anyway, that's the area that we're working on, where we're looking for direct and indirect effects, and we explicitly acknowledge that we've got problems of confounding, or that we know. So that's the Barron and Kenny model. I'm not going to talk about anything to do with statistics per se or algebra or anything. It's mainly going to be pictures and a few words. So that's the Barron and Kenny model. Intervention influences the mediator, which in turn influences the outcome, and there may be a direct effect of the intervention on the outcome. And what we're trying to do is evaluate the relative proportions of those pathways. So that's probably more like real life. We have hidden confounders everywhere. You can probably screw up any of the estimates for these causal effects. And this is quite an intractable problem if that really is the case. So what's the advantage of randomization? Why do we work with trials? Well, if we work with trials, we can block quite a bit of that confounding. And so what we finish up with is that. We can't control the mediator by randomization, because we're just randomizing the initial intervention. But we can make sure that there's no confounding of the effect of randomization on the mediator. There's no confounding of the effect or the overall effect of randomization on the outcome. That all results of the design. But the effect of the mediator on the outcome is confounded. And if the direct effects and indirect effects add up, then that directly influences the size of the direct effect as well. So you're still left with this problem of trying to estimate the relative sizes of the direct and indirect effects because of that mediator, that confounding up there on the right. So this is the basic problem that we're trying to solve. We can't solve that with data collected exactly like that. We need more information. Nick has mentioned instruments. So, IV, instrumental variable. If we can plug in an instrumental variable there, which is not randomization in this more complicated situation, because we're trying to estimate a direct effect of randomization, so we can't use this as an instrument here because we've assumed that that's present. If we dropped that, then randomization would be an instrument. So the question is, where can we find those extra instrumental variables to enable our model to be identified and so that we can estimate the different path sizes? Randomization by covariant interactions are usually the approach that we've taken. Many of these trials are stratified by treatment centre. They're multi-centre trials, so typically one of our larger cognitive behaviour therapy trials would be run in, say, 3, 4, 5 centres around the country, based on different universities, Manchester, Bristol, London, Glasgow. And the effect of the random intervention on the mediator is quite often different in the different trials. The therapists have a different effectiveness. We don't know why, but it just happens to give us a handle on finding this interaction. So we have a randomization by centre interaction. If we had the luxury of having several large trials run in parallel or sequentially using the same outcomes, the same measures of mediators and so on, we could use some sort of meta-regression or meta-analysis to combine data from trials where we assume that there is a trial by randomization interaction. That's something that's just a fantasy at the moment, because we just don't have that sort of data. We could try building in those sort of interventions by design, which we're trying to do in some trials, but I don't want to talk about that in detail. And the question is always, comes back to, I criticise people using the Barrow and Kenny assumptions, that people are making them without knowing what they're doing, or without being aware of them. It's important that we then ask, what else are we assuming in order for that model to be identified? And it's what's missing from the model that is the important thing. So we're saying that there's a interaction effect here influencing this, but there's no link between that and that. That's an instrumental variable assumption. But these things are homogeneous. There's no mediator by intervention, interaction, so on. So we assume that once we've got through to the mediator, the effect of the mediator on outcome, for instance, is the same in all trials, it's the same in all treatment centres. Now that's a pretty tall order, so we might have got it completely wrong, but that's our current assumption. But I think the important thing is that we're familiar with it, that we make people aware of it, and we discuss it. Well, not very good at this. So, let's change direction slightly. Let's look at the effect of the Therapeutic Alliance. What is a typical analysis strategy? This is even simpler than the Barrow and Kenny stuff. Typically, people ignore the control group. We can't measure alliance in the control group. They haven't been anywhere near a therapist. They've usually just had treatment as usual or neglect as usual. We look at the correlation between the alliance score and the outcome, and we get a positive association, and we then lead to the conclusion that that positive correlation is an indication of the causal influence of alliance on treatment effect. We're not measuring treatment effect, we're just looking at a relationship within one arm of the trial. And that analysis is flawed. That data can't distinguish between effects of prognosis and effects of treatment. People who are capable of forming a good therapeutic alliance are also the ones who may well have done better even if they didn't go anywhere near a therapist. They're ones with the best insight, the best social skills, and so on. So we need data to be able to separate those things. So what we really want to know is, for someone who's received treatment, they've developed a certain level of therapeutic alliance, let's say they've developed a really good therapeutic alliance, what would their outcome have been if, contrary to the fact they've been in the control group? So you're basically wanting to stratify on the level of alliance, even though you've not measured it in the control group. It's a missing data problem. If we look at the effects of sessions of therapy attended, again, the traditional method is quite similar. Ignore the control group, or possibly include the control group and call them 0, and then just do a naive regression, or a naive correlation. And again, there's selection effects, there's confounding. People who attend so many sessions could either be more or less likely to get better, even in the absence of treatment. So it's not just a case that the more sessions you attend, the more likely you are to get better. It's not just the case that the more sessions you attend, the better the treatment effect. There's a complex mix of different causes. This is a slightly simpler problem because at least we know that people in the control group haven't had any sessions, or perhaps if they've managed to get access to therapy, we know roughly how many sessions they've had. So here we're in a simpler situation where randomisation is assumed a priori not to have any influence on outcome other than treatment received. So there's no direct effect. Now that may be wrong still. Quite often in a trial where it's very difficult to blind, allocation and so on, there's all sorts of subjects of assessments going on, just the process of offering treatment, even if you don't turn up, could possibly influence outcome. So again, you can't get a handle, as Nick was saying, it's not just stats. You can't get a handle on those causal effects without putting in lots of assumptions about what you think is going on. And those assumptions, some of them you can test, some of them are not testable. So this is a simple instrumental variable model. Whoops. If we have more than one instrumental variable, so we've got this randomization by baseline covariate interactions, that is the model. So I've allowed covariates to influence mediator and outcome, as if they're observed confounders, and then we have this randomization by covariate interaction being an additional IB. This gets us a bit more power, but not a lot more. But we can now think of it in terms of what's called G-estimation, or a G-estimation algorithm, which might help explain what's going on. And this is exactly equivalent to this instrumental variable model that I've just given. So what we do is we regress sessions attended in the treatment group on the covariates. Can we predict how many sessions people attend in that group that have been offered therapy? And then we use, it's an imputation procedure in a sense, we then use that regression model to predict sessions attended in everybody in the trial. So we have a predicted value for the people in the treatment group, we've got a predicted value for those people in the controls. So we've got people, for instance, a bit like the propensity score business, where we could match. We've got people with a predicted value of 10 sessions. What's the difference in outcome? We regress the outcome in the treatment group on the covariates and predict that. So that's predicting the treatment outcome in everybody in the trial. We regress the outcome in the control group on the same covariates, and we predict the treatment-free outcome for everybody in the trial. So now we can subtract one from the other to get an individual treatment effect, or a predicted individual treatment effect. And if we regress that difference on the predicted therapeutic dose or number of sessions, that is the effect of sessions on the treatment effect. So it's not the effect of sessions on the outcome, it's on the effect of sessions on the difference between treatment and control. So we're still using this randomized procedure. We're basically trying to get an estimate of the effect of randomization on people who will attend, say, 8 sessions if they're offered it. And obviously, if you do this naively, there's a bit of a problem with standard errors, so there's a technical bit on the end where we have to make some sort of adjustment to get correct standard errors. The cheerful way of doing it these days is just to bootstrap the whole thing. We could have a similar algorithm for the effects of the Therapeutic Alliance. So basically, if we had just 2 levels of Therapeutic Alliance, good and bad, we could say what predicts good alliance in the treatment group, and then we'd say predict those people in the control group. So you finish up with latent classes, good and bad, available in each group, and then what you want to know is what's the effect of randomization in each of those groups. Here we've got a continuous measure of alliance. Use a very similar algorithm. We could also look at the joint effect of sessions and alliance. And the model that I've used in the past is one that has an overall effect of sessions and then a modifying effect of alliance. So it's a model with an interaction term in it. We could use a regression model to predict S, or another one to predict AS, and then regress the predicted treatment effect on both S and AS. And what that tends to imply, but again, it's based on a data set that's been highly selected, but in the data set that we used on this, it looked as if you had a good alliance, attending more sessions is a good thing. It increased the benefit of the therapy. If you had a bad alliance, it actually made it worse. And one of the problems with all this stuff, and I guess it was the thing that went through my mind when Mark was talking, is how much of this sensitivity analysis would you do with these statistical methods if you got results that you were expecting? And it's the surprising results that make you step back and say, well, what have I screwed up on now? What have I assumed that probably isn't valid? So one of the things that I guess Stevenson in a book on medical statistics several years ago sort of asked what was the defining characteristic of a medical statistician, and he described it as someone who gets the results they want, they look really fine, and then they say, hang on a minute, what have we done wrong? What's the other explanation? And I think one of the things about this sort of work is that you soon come to the conclusion that it's very difficult to get what you might confidently say this is the right answer. It just sows doubt all over the place. And one of the things that you have to be aware of is that it doesn't sow too much doubt, you give up on the exercise. It's a fascinating area, but it's the negative results, the surprising results that makes you think even more carefully about what we're doing. So we're dealing with just to conclude, we're dealing with observational problem, basically observational data where the subjects themselves are deciding what they're going to do they turn up for therapy and so on, embedded within a randomized controlled trial, embedded within a randomized experiment. And it's that randomized experiment that gives you an extra handle on trying to find out what's going on. But if you're looking at causal connections in a fairly complex situation without any experimental control, it's a much more difficult problem. So I do tend to doubt what on earth you can learn from observational studies, to be honest. So randomization enables us to estimate effects that would be very difficult or impossible using data from simple observational studies, unless we could find another convincing instrument or set of instruments. And it is quite difficult to find them. And the ones that you find in the literature, yeah, they sort of work, but they're not desperately convincing. The estimation procedures are very dependent on prior assumptions, lots of them. And these are the things that should always be questioned. And I've not mentioned any, I've not shown you any, but the estimates tend to be relatively imprecise. So you'll basically by making more defensible assumptions, there's a cost to pay. You're getting something that's less biased, but it tends to be much less precise. So you might prefer the biased but precise estimate, depending on the context. And we need to think far more about design in these trials in particular. Thank you. And there's a few references there. I gather this is going to be on the website, so you'll be able to find it. And if you're interested in our work on the Biostats Group website as well, there's quite a lot of material, including downloads, so on. Thank you very much.